Good morning, everyone. Myself, Dr Maheshwari. I'll be talking on our comparison of outcomes of pars plana vitrectomy with inverted ILM flap versus scleral graft for optic disc pit maculopathy. So, ONH pit is a rare congenital anomaly with prevalence of 1 is to 11,000, thought to result from failure closure of fetal fissure, appears as a small hypopigmented gray white depression, usually located in the temporal part of the optic disc. It is usually asymptomatic. But pit maculopathy is characterized by the presence of retinal schisis and serous macular detachment seen in up to 25 to 75% of the patients. The treatment options include spontaneous resolution, laser photocoagulation, macular buckling surgery, inner retinal fenestration, and pars plana vitrectomy with plugging of the pit. The aim of this study was to evaluate the anatomical and visual outcomes in optic disc pit maculopathy following PPV with inverted ILM flap versus scleral autograft. It is a retrospective study. Inclusion criteria was patients who underwent this procedure between March 2017 to July 2022, people who had a coexisting ocular pathologies affecting vision and lost to follow-up before 1 year were excluded from this study. The preoperative evaluation included slit lamp biomicroscopy, fundus examination, OCT, Snellen's BCVA, IOP, and informed consent was taken from all the patients. Surgery included pars plana vitrectomy with either inverted ILM technique or scleral graft technique, and post-operatively it was seen day 1, 15, 30, and 3 monthly for 1 year. This is a video demonstrating the ILM peeling technique. After pars plana vitrectomy and induction of the PVD, BBG dye is used to stain the ILM. After this, supero-nasal to the macula, ILM flap is raised. Foveal sparing ILM flap is raised and then it is tucked into the optic disc pit. Careful fluid air exchange is done nasal to the disc, and after confirming that the ILM is in place, gas tamponade is placed. So coming to the scleral graft technique, pars plana vitrectomy with induction of PVD was done, following which a partial thickness scleral graft was used, was dissected, and then it was sized according to the cutter width which we used to measure approximately, and then it was placed over the optic disc pit. Following which, careful fluid air exchange was done, and confirming the graft in position, gas tamponade was advised and prone position was advised for 2 weeks. Coming to the results, the ILM peeling technique included 10 eyes and the scleral graft technique included 11 eyes. The mean age was comparable in two groups with 27 years, and mean best corrected, this is a box plot demonstrating representation of visual acuity at baseline and 1 year post-operatively. In scleral graft group, the baseline visual acuity at the presentation was 0.58 logmer, improving to 0.53 at 1 year, and in ILM peeling group, it was 0.91 logmer, improving to 0.58 logmer. There was statistically significant improvement in ILM group, but since the baseline visual acuity was worse in ILM group, this was not statistically significant between the groups. This is representation of central macular thickness at baseline and 1 year. In scleral graft group, it was 1220 microns, improving to 276 microns. And ILM peeling group, it was 804 microns, improving to 273 microns. There was significant reduction in both the groups, but there was no statistically significant difference between the groups. So these are some OCT images pre-operative, which was treated through the fovea showing schisis of inner and outer retinal layers treated by ILM flap, and post-operatively at 1 year showing resolution of subretinal fluid and minimal inner retinal schisis. This is a patient with preoperative OCT through disc and fovea showing optic pit with schisis treated with scleral graft at 1 year showing near total resolution of the SRF. So coming to the discussion, 21 eyes of optic disc pit maculopathy were studied. They were unilateral and located in the temporal half of ONH in all patients. Incidence was seen equally in males and females. The purpose of this treatment was to produce a permanent barrier for fluid migration out of the pit. And one patient had a scleral graft displacement, which was treated by repositioning of the graft and silicone oil injection. So coming to few literature research, the EVRS study for this optic study, PIT study showed 25 surgeons around 12 countries with 95 eyes showed higher rates of resolution of SRF and IRF with pars plana compared to the laser. And another study by Naresh Babu et al. Was a retrospective study which compared between ILM peeling, ILM flap and scleral plug, which showed better surgical outcomes if the pit was plugged. So to conclude, the modified techniques of pars plana vitrectomy and plugging of pit were using foveal sparing inverted ILM flap and scleral graft for the treatment of pit maculopathy results in good anatomical and functional outcomes. Statistically, both techniques are similar and with regards to surgical outcomes in terms of central macular thickness, serous macular detachment resolution and visual acuity. And surgical intervention may also help in the long-term stabilization of the disease with faster resolution of the SRF. Thank you.
Basically, looking at your study, still now previously we discussed what is the source of SRF, subretinal fluid you think here?
Sir, as she already said, it is either CSF or vitromacular traction. Since I cannot postulate what is the theory, but we have induced PVD in all the cases. So we try to eliminate the factor which is vitromacular traction, vitropit traction, and since we are plugging, even the CSF source has.
That's eyes where ILM is covered. That's why you said better outcome, right?
No, that is because two patients had worse visual acuity at the time of presentation in ILM group. So they had worse visual acuity at the time of presentation. But both the group improved significantly. Since the baseline visual acuity in ILM group was worse, there was difference between the two groups.
So
otherwise,
you think other group has a ceiling effect?
Both the groups has a ceiling effect.
So now you move to which techniques in your study? Which is the technique of
Sir, this was. There is no based on whether at the time of presentation or at the time, it is based on surgeon's preference. Of presentation,
If I have to walk out of this hall, what you want to take a muscle, which technique I should follow?
it is based on the comfort of the surgeon. Both the techniques are equally effective because neither of the visual acuity pre-op and post-op was affected by the type of the group and resolution of the SR. Since we are taking partial thickness, I think it should.
We are damaging some anatomical structure there. ILM is a part of your surgery. We are increasing one more step. I'll offer you, I'll trigger that ILM better.
Totally, surgeons feel so. Totally, for surgeons feel so.
Sir, Dr. Maheshwari, one thing that graft, how do you feel? What is the adhesion property? How it is getting adhered to the pit? And you have one patient who got dislodged.
Yes, sir.
So I think it's technically there's a high possibility will dislodge because it's not having any initial adhesion. So what actually is your technique? How do you feel that it's getting adhered to the pit?
I think it's because of the autologous graft. I think it's mechanical, it occludes and then stays in position. And all the patients who were not dislodged after 15 days had no dislodgement post that. So the mechanical plugging is what I feel.
We'll move to last. Thank you.